severe or significant, how it happens in other patients with septic coagulopathy. So this is something of an interest. People are having controversial things of either to use heparin or anticoagulation or not to use anticoagulation. But before saying anything, we have to build up some more data. And one more thing which people regularly ask me, even my patients who are admitted right now, is every day in and day out we give some transfusion. So it's a big time thing that people, yes, the blood test is done in the blood, the viremia is there in the blood, but will blood component and blood donation or the blood bond, is it a blood bond? That is, people are worried about getting blood transfusions also. Quite a controversial thing to say here, but till this time, whatever the WHO or ICM or whatever they're saying is blood and blood component transfusion seems to be unlikely. But the transfusion, what's it, the council or the body is trying to make up some protocols of how to choose a donor when choosing a, regular blood donor itself. I'm saying, do we need to wait for the incubation period before the blood can be given to somebody, or is it necessary to do a PCR in all the donors who are coming, which at this point in time seems very not so practical. But I think some clarity on that blood component transfusion is going to come up maybe at the end of this month, I suppose. We have to wait for it. Next, please. Dr. Amit, next slide. Yeah, I thought I'll just have a fast run through about the drugs which are right now in the trial for this COVID infection. Why? Because there is a panic situation everywhere. Trump is asking India to send all the hydroxychloroquine, not even knowing whether the hydroxychloroquine is really going to be useful. And there are some anecdotal evidences coming up everywhere that patients are kind of losing their lives because of the QT prolongation or whatever. So why I am putting this list of medications is, it's very well possible that some of our patients already they're having a very high health anxiety. Some of the patients, due to health anxiety, may be taking these drugs without even our knowledge, for that matter, over-the-counter drugs or wherever they get it, and they will be on a hydroxychloroquine or azithromycin. And ultimately, we end up adding some chemotherapy or another drug which has got an additive effect or an adverse side effect with the other drug. So we should be kind of careful. So try to ask your patients who are on an OP basis if they are unfortunately or fortunately on any of these drugs, or they have been exposed to. So, but very interesting that most of the regular drugs what we have been using are being used in the treatment of COVID. So these are all anecdotal evidences. Solid data is yet to build up. But unfortunately, there's nobody who's that much confident enough to say that these drugs do. To be more frank, many of the in vitro studies are there. Even if you say alcohol hand rub or a soap is going to have an in vitro effect on the virus, so it doesn't mean that we are going to take in and clear the virus. So we really don't know. We have to wait for some data to build up on this. Next slide, please. Yeah, now as I said, as not only in the diagnosis of COVID, sometimes as hematologist, there are a lot of papers coming up with convalescent plasma, and people are really interested in. Even in India, the ICMR has given some, as a part of a clinical trial, they are approving some centers to use this convalescent plasma therapy. I will discuss in detail about the convalescent plasma at the end of the session. So these are all the places where we may be called in for even treating this COVID patients. Another thing that is building up, just now I saw on ICMR website that they even call for a clinical trial involving plasma exchange. I really don't know what is going to be the protocol for it, but still these are all esoteric methods which people are just trying to do as clinical trials. And as I said, use of routine anticoagulation, the questions are being asked again and again, and generally use of IVIG as a prophylaxis is also being done. So these are all the places where our help may be needed as hematologists when even treating COVID patients. Next slide, please. Yeah, that's all about COVID patients and their hematological parameters, something to do with therapy of them, etc. Now we'll come to the actual care of hematology patients per se in the COVID epidemic. So this was one of the very early papers which came in BJH when the Britain started having cases. Next slide. Yeah, this paper was actually spotting out what was happening in Wuhan, the actual epicenter of all this COVID infection, where the oncology center reported that, as I said, the mortality was really, really higher. And most of the transmissions were happening through hospital-based transmissions in hemato-oncology patients, because most of them are in the wards. And this was kind of, it was a disaster, I should say. So our patients getting it better, prevention is better than cure at this point. So we have to be doing each and everything what we can from our end so that we prevent these patients from getting some kind of a COVID. Next slide, please. Yeah, so I thought to start with, I'll just, as I just said, we becoming carriers and spreading infection to the frail patients is the last disaster to take place. So I'll talk a few things about how at this point in time, how to manage our OPs, clinics, and a few words about telemedicine, because that's probably seems to be the what to say, the big time thing for the next few months to come. So when it comes to clinic management, I'll be discussing what we have done once the COVID started coming into our place, because Tamil Nadu is ranking third on COVID patients with around 1,000 plus patients in the state, and Chennai alone has got 200 patients who are proven. So first thing what we did in the start of, say not start of, maybe 3 weeks or 4 weeks back was, first thing I will say, if you're a private practitioner having your own OP practice, and if you're sure that you can't be following all the protocols which WHO is putting forward to look at patients, the best possible thing is to stop your or close down your OP, stop seeing patients in a private OP for that matter. We have seen 3 doctors here, not oncologists per se, but orthopedicians and other. Unfortunately, we lost one also just because of the simple issue of continuing a OP practice with non-specific people coming in, and we don't, not only the patients, maybe the attenders also. So that's my, I should say, not a suggestion. To be more, I'm pleading to you guys to stop your standalone private practices where it's very, very tough to follow all the PPE measures, at least for the next month or so. Coming to bigger hospitals, what most hospitals we are trying to follow here is, at least what my hospital follows, I can share it with you. Immediately at the start of this epidemic, we divided the hospital itself, because we got 2-3 blocks separately. So we divided the blocks into a COVID and a non-COVID block. Basically, the COVID block means all the respiratory block, I should say. So any patient on the road itself entering the hospital, there will be a very minimal check by the people who are there in the, sorry, I should say the front gate itself, for a thermal screening and all those things. Anybody with a cough, fever, or any complaints for that matter, directly they are forwarded to the COVID block. But there may be some patients who are having very milder symptoms, and they're really panicky to say these symptoms to the doctors, or they may be our routine patients, so they really, really want to see us and then take a decision. Sometimes those patients may be denying the symptoms, and they do end up in the non-COVID area also. So non-COVID area, what we did was we kind of closed all the entries. We just made it as that block as a single point of entry. In the single point of entry, we have kind of employed general medicine people who, with proper PPE, will do a second level of screening, so that asking questions is the travel history, just checking some basic vitals, looking sometimes even a basic hospitalization for that matter, and kind of making sure that on a relative terms, the risk of COVID infection may be less in the patient. Why? Because to be more frank, whatever said and done, it's very, very impossible that everybody wears a PPE and sit in the all specialty OPs. At the end of the day, I end up only seeing 5 patients or 6 patients. We don't have that much of PPEs, at least in this point in time, but we need protection. So what we have really taken a step is to kind of reserve all the PPEs for the frontline staff who are working with directly working with a known or suspected COVID patients, so that the rest of the people, we are trying to make some kind of arrangement so that we reduce the risk of transmission. So in this level, the non-COVID zone where the initial screening is done, if the patient is an adult, really stable vitals, we ask only the patient to enter into the specialty clinic with a limited number of paper sessions. If it's a pediatric or a wheelchair-bound patient, we kind of allow only one attendee. That's very important. No more than one attendee per patient. This just reduces the cluttering and clouding in the OPDs also. We don't want patients to get infected during the waiting time in OPD. As doctors, it's not that I'm wearing PPE and seeing the patients, but one thing I do is at least a 3-layer mask, or if good enough, an N95 mask also, depends on your area of practice for that matter. One good thing is to get the OPD totally clutter-free. No nonsense, nothing, no papers, only a system to work on and maybe 1 or 2 papers to write, that's all. So that this helps in the cleaning process also. Wherever there is a possibility of a touch or whatever, it should be properly cleaned with an alcohol-based cleaning solution. Floor and everything should be placed with a 5% or 1% Lysol solution for that matter. And we have made it as a practice to even fumigate with hydrogen peroxide based fumigators after the OP gets. We have cut down our OP times to only 50% of what we have been doing before. That's more than enough. However busy you are, that's more than enough, because it indicates some, what to say, basic safety for you also. And one thing what we did was, like, yes, there are only 2 chairs, one for the patient and the attending, so a good distance of at least a meter or so. And every time after examination, it's better to have our steps or whatsoever cleaned by alcohol-based rub solutions. One more thing, bare below elbow, nothing in and out of the hospital, only a single, you just wear a dress, no belt, no wallet, nothing. Just enter in, keys and everything, mobile, everything should be properly cleaned once you're getting out. You may be just wondering why I'm stressing a lot, because after seeing 5 or 6 patients, doctors getting COVID here, I personally feel, is it all worth it at the end of the day? So please, I think whatever you can follow, don't have any I should say in Hindi, if I want to put it, don't have any sharam of doing all this, please. It is for your own safety, not for your own safety, the people who are depending on you at your home also. So that is very important. So I think this kind of we have to follow it more judiciously to prevent ourselves getting COVID infection. That's all. Coming to telemedicine part, yes, on 25th of March 2020, the Niti Aayog and ICMR, they have put out a detailed document on how the telemedicine guidelines are going to be. So if you're really, really interested, you can always go through it, and that's more valid now. But unfortunately, chemotherapy drugs is still not included in the list of drugs which can be prescribed in the telemedicine field. But there are two ways of looking at telemedicine. If it's a older patients, what we have done is send an SMS, email, or whatsoever. We have got patient contact that all chronic patients like CML follow-ups, lymphoma follow-ups, myeloma follow-ups, everybody asks them to be at home at least till the end of May. And if really they want to get a review with us, do some home collection of blood test and send it through an email or whatsoever, and they get the advices. If it is a source originating from an unknown patient, that is a new patient for you, what we have done is we are not directly engaging this new patient because we really don't know what's happening. So we try to get these patients, ask these patients to go to the nearest available medical facility, which may be very small medical facility. Try to do a telemedicine with a healthcare personnel there. That makes a lot of sense because we really don't know about these patients, what is their condition. So that is very much feasible, doing a telemedicine not only directly with the patients, but also with the local healthcare personnel, which will very much reduce your load on the OPD. Yes, I definitely know that this is not possible in all settings, and the settings which don't have or keep the patient data in a correct way or maybe not in a digital way, it is very tough. But I think it's slowly over the time, I think it is very well possible. If we can do it, that's an easier way to protect both us and others. So telemedicine is not going to be free of cost also. If you really want, there are a lot of platforms which can properly charge and then get a telemedicine. That may be the worry for a lot of people. So these are some basic things which and when it comes to next slide please. Yeah, these are the basic concerns what any specialty people can follow. But when it comes to hematology, the situation, when it comes to inpatient treatment in hematology, there are some special considerations to be made. The biggest problem once the lockdown was announced or even the panic of COVID started was about the blood banks. At present, most of the blood banks, government or private, who used to run camps or whatsoever, everybody is running at a stock of around 20-25%. Many hospitals we heavily depend upon the surgeries, elective surgeries which are going on, so that the people who are coming for surgeries used to donate 4 or 5 units of blood. But unfortunately, that has been stopped for the last 1 or 2 weeks, and so this is a real crisis. Even blood RBCs, for that matter, because of the long half-life, that's all fine. Shelf life, that's all fine. But when it comes to platelets, it has been a big time struggle. So this has actually prevented us from even venturing out into things like transplants and all at this point. I really, really worry in the middle of a transplant if the patient gets into a big time problem of low platelets. That's the last thing I want to happen. So knowingly, I shouldn't be putting the patient's life into jeopardy. But still, what we are trying to do, anybody who is coming into the OP attenders or the patient attenders, we are issuing certificates and asking them to come and donate blood, which place to place it differs how we are going to mobilize. Unfortunately, camps are not going to happen at least for next 6 months for that matter. So this is the situation everywhere. And maximum are trying to mobilize SDP, collect a double dose of STB up to 400 or 450 ml, and divide it into 2 or 3, and then try to use it in 1 or 2 patients. This is what we are doing. And when it comes to invasive procedures, as an oncologist or hematologist, the maximum invasive procedure I'm going to do is a central line or a quick line, which unfortunately has to be done if it is needed. But when it comes to marrow and LP, that is lumbar puncture, marrow, I become very pick and choosy, I should say. All the regular staging marrows for lymphomas or marrows done for PUOs. We don't know, PU may be a COVID also. So the MPNs except myelofibrosis, these are all a year stop me. Even if the peripheral blood has got blast and the WBC counts are more than 5,000, we prefer sending a peripheral blood flow cytometry by concentration methods rather than even poking the patient. We just don't want to keep on exposing the patient to different situations. Try to keep the exposure to the minimum. That's what we are doing. And when we started it, yes, we thought all transplants need to wait now because of the logistical issues of multiple things. But slowly we are thinking there are some patients who, unless we do a transplant, they're going to go away. So there are special situations which I will discuss towards the end of it. Next slide, please. Yeah, coming to our medications, when I say hematology, the basic thing in hematology, I should say, is almost always steroids. As you saw in treatment,